A very good morning to all of you. Firstly, I thank Vignesh sir for making me part of this wonderful IC, and it's an honor to be speaking among these star worlds on the stage. And I also thank the scientific committee, AOS and APO for giving me this opportunity. So in the next few minutes, I'll be covering the topic of phaco in small pupils. So there are no financial disclosures. So the scope of this talk would be under the following headings: a brief background, what is the critical pupil size that we consider as a small pupil, a stepladder approach, and expansion device options, and tips and videos I'll be showing you, and a take-home message. So if you see, we will encounter 7 to 10% of the cases that we do routinely that we encounter small pupil in a cataract surgery. And the most common causes that we see in our practice are pseudoexfoliation, diabetic patients, post-uveitic cataract where you have synechiae, and also floppy iris, which has been rising in the recent past. So why is it important to handle these cases well? So if you see, a lot of studies suggest that the risk of PCR is 3 times more in these cases because of the difficulty in doing rexes and the reduced red glow because of a small pupil. And also you have 5 times more chances of damaging the iris while you're doing these cases. So what is critical pupil size? So if you see any pupil that is below 4 mm, you can safely consider it as a small pupil. Anything that is above 5, basically correlating to your capsulorhexis size. So if you have a pupil that is equal or more than your capsulorhexis, that is usually 5, then you can take a call whether you want to use an expansion device or you want to manage it with a viscometry assisting. So to take that call, there are 4 factors that you have to consider. One is the surgeon experience, the phaco technique that you are going to use, and at which step the surgical meiosis has happened. It's already meiosed from the starting, or because of some step intraoperatively it has gone into meiosis. And also most important is the iris behavior, whether it is elastic or rigid. This differentiation makes all the difference. Even if you have a pupil size of 5 and it is elastic, especially in floppy iris, though it will have a good dilatation initially, by the mid-surgery it will go back to 3 or 2.5 where it initially was. So this differentiation would be very important. So coming to surgeon experience and phaco technique, so viscomydriasis is the most common thing all of us tend to start off with. So you can use a dispersive visco like a Helon here, decrease your phacofluidics, flow rate from 25 to 30, vacuum from 300 to 350. And the preferred thing is a vertical chop, and I prefer to get it out of the bag, do a good endothelial coating, and do chip by chip, flip and chip kind of a technique, because when you flip this entire nucleus, the equator acts like a pupil expander and it will keep the pupil open. So once you do that cartwheel thing, chip and chip, you can easily eat this thing. And the one important thing is you have to avoid this technique in early and cheesy cataracts. In soft cataracts, this would not be an ideal technique because you will not have a good hold. And ideal cases for this technique would be a grade 2 to 3 cataract. Brown cataracts, as sir has already mentioned, I would prefer to do an SICS with sphincterotomies and a large rexis rather than going to a phaco in such cases where the pupil is small. So coming to the stepladder pupil expansion technique. So one is we can start off with the pre-op itself. So preoperatively, you can start using atropine 3 times a day prior to surgery. We can also add nepafenac TID in diabetic and uveitic patients, especially to maintain good mydriasis intraoperatively. Intraoperatively, now we have good commercially available tropicamide, phenylephrine, lidocaine combinations that are there. Previously, we used to use eptrate or adrenaline. So with this, next step would be the viscomydriasis. So viscomydriasis, the practical thing is you should not inject the visco in the center or above the capsule, but you have to put it like a mechanical push at the edge of the iris margin so that it opens up. Next would be synecholysis when you suspect a synechiae, posterior synechiae in case of uveitic cataract. And next you can attempt stretch pupilloplasty that also works very well in 20 to 30% of the cases. So coming to pupil expansion, I had my experience with them is limited to what is shown here. So I started off with iris hooks, then I tried the ASIA hooks, then the B-Hex. B-Hex now has 2 models, the version 1 and version 2. Next we have the Gupta ring, and recently from Arvind we have the Innova developed by Dr. Vivek. So if you see, what I would suggest is, for beginners, I think you can start off with iris hooks. Then Gupta ring is easier to handle when compared to the BHEX of previous version. Taking this into feedback, now they have developed BHEX 2.0 that is sturdier and easy to manage. The BHEX 1.0 was very thin and it was difficult to maneuver. And now I think INOVA has a promising future with the circular expansion, easy insertion and removal. So recently there was an article in IJO comparing the pupil expansion devices in small pupil, very recent article. And in this they have compared the most common things we use, that is the iris hooks, BHEX and the Gupta ring. These are the common things we use in India. And they found out that all of them have comparative results, whereas the iris hooks took longer time, but the learning curve is less when compared to the pupil expanding devices. Once you are comfortable with pupil expanders, maybe you can start using the Gupta ring or the BHEX 2. So this is the BHEX 1.0, which has the thick, strong flanks and thin fiber notch hairs and tabs for holding. So this is the video. So it can go in through your regular 2.8 incision. So once you insert it, then you have to make 2 side ports and maneuver it bimanually to engage it in the pupillary margin. Once you place the lens, you can gently remove it, and removal is fairly straightforward. Especially the version 1 is very sleek and it comes out like a breeze. So next we have the Asia expander, which is very easy to use again. This also you can start as your initial pupil expander device. So it goes through your regular side ports. You need not create any extra ports like the iris expander. So once it goes inside, it opens up like those arms beautifully and gives you a nice rectangular opening. And once the lens is placed, you can easily clip them off and remove them through the side port incisions. So take home is, know your critical pupil size and try to use expansion device as the last step in the step ladder approach, because whatever expansion device you are going to use, you are going to create some kind of a sphincter damage. So if you are able to manage with your experience with help of a visco and other techniques that I have discussed, it would be the best option. 30 to 40% of the cases you can get away. Differentiate between rigid and elastic pupil. Elastic pupil is more challenging. Optimize your phaco parameters. Take care of the endothelium. To start off with, you can start off with the Gupta ring or BHEX 2 that's available. Iris hooks still remain a good option. INOVA is an evolving design that has a promising future. Thank you for your time and attention.
Madhu, thank you for the excellent